Welcome to Health Code Blueprint. Today, we're covering coding scenarios to reinforce proper ICD-10-CM code selection following the ICD-10-CM guidelines. Chapter 12. Diseases of the Skin and Subcutaneous Tissue, L00, L99. We'll walk through key definitions, the severity spectrum, and the inpatient evolution rules that shape accurate coding. Disclosure. This presentation is intended for educational purposes only. It does not constitute legal, compliance, or billing advice. Always refer to official coding guidelines, organizational policies, and regulatory requirements when making coding decisions. Let's get started. Chapter 12 covers a wide range of skin and soft tissue conditions, but today we're focusing specifically on pressure ulcers and chronic wounds. These codes rely heavily on two things: anatomy and severity. Once you understand how those two pieces fit together, the rest of the logic becomes much easier to navigate. A pressure ulcer is localized damage to the skin and underlying tissue, usually over a bony prominence, caused by pressure, shear, or friction. Coding pressure ulcers is basically a two-part equation. You need the site, where the ulcer is located, and the stage, how deep the tissue damage goes. Codes in category L89 combine both pieces. And remember the volume rule: if the patient has multiple pressure ulcers, you assign a code for each one. No bundling. Pressure ulcer stages reflect the depth of tissue involvement, ranging from superficial skin damage to full-thickness tissue loss. Let's walk through the severity spectrum. Stage 1 is the earliest, with intact skin and non-blanchable redness. Stage 2 involves partial thickness skin loss, think blister or shallow open ulcer. Stage 3 goes deeper into subcutaneous tissue. Stage 4 extends all the way to muscle or bone. Then we have deep tissue pressure injuries, which involve persistent, non-blanchable deep red or purple discoloration. And finally, unstageable and unspecified, two terms that sound similar but mean very different things. An unstageable ulcer is one where the true depth cannot be determined because the wound is physically covered. An unspecified stage means the provider simply didn't document the stage. This is one of the biggest gray areas for coders. Unstageable means the clinician cannot see the base of the wound. Maybe it's covered by a scar or a graft. Unspecified means the documentation is incomplete, the provider didn't record the stage. One is a clinical limitation, the other is a documentation gap. And mixing them up leads to incorrect coding, so it's important to keep them separate. Debridement is the removal of dead or obstructing tissue to expose the true wound bed. Here's the rule: if an ulcer is unstageable on admission but debridement reveals the true stage during the same encounter, you code only the revealed stage. You do not code the initial unstageable status. Once the true depth is known, that becomes the official stage for coding. A healed ulcer is fully resolved with intact skin. A healing ulcer is improving but still present. When a patient is admitted with a completely healed ulcer, there's nothing to code, the condition no longer exists. But if the documentation says healing, that means the ulcer is still active. If the provider doesn't specify the stage, you assign unspecified stage. Healing still requires coding, healed does not. Sometimes the documentation isn't clear. Is this a new ulcer? Is it a healing ulcer from a previous encounter? If the provider doesn't make that distinction, you query. The same applies when the stage is described using terms that don't appear in the alphabetic index. When in doubt, ask. That's the safest path. Ulcer progression refers to a wound worsening to a higher stage during the hospital stay. If an ulcer progresses during the admission, for example, from stage 2 to stage 3, you assign two codes, one for the stage on admission, and one for the highest stage reached during the stay. This captures both the patient's condition and the resource use. Even if the ulcer heals completely by discharge, you still code the admission stage. Coding reflects the condition that required treatment and resources during the stay, not the final outcome. So healed at discharge doesn't erase the need to code the ulcer. A non-pressure ulcer is a wound caused by factors other than pressure, such as vascular disease, diabetes, or trauma. Non-pressure ulcers follow similar logic but use severity levels instead of stages. If the ulcer is healed on admission, no code is assigned. If the ulcer is healing, you code the severity, or unspecified if the documentation doesn't provide details. And if it's unclear whether the ulcer is new or healing, you query. Just like pressure ulcers, if a non-pressure ulcer worsens during the stay, you assign two codes, one for admission severity and one for the highest severity documented. And if it heals by discharge, you still code based on the admission status. Here's an important distinction: the provider must document the diagnosis of the ulcer, but the clinician, like a nurse or therapist, can document the stage or severity. So staging doesn't require a provider note, but the diagnosis itself does. Here's your quick mental checklist. Always code all documented ulcers. Always code the admission stage, even if the ulcer heals. Always assign 2 codes if the ulcer progresses. And always query when documentation is unclear. On the flip side, never code ulcers documented as completely healed, never confuse unstageable with unspecified, and never code the initial unstageable status if debridement reveals the true stage. Let's look at a few quick examples. If a patient is admitted with a stage 2 ulcer that progresses to stage 3, you code both. If a stage 3 ulcer is completely healed by discharge, you still code stage 3. And if the provider documents a healing sacral ulcer with no stage, you assign unspecified stage. Accurate coding in Chapter 12 isn't just about compliance, it reflects the true severity of the patient's condition and the resources used to treat it. When we code precisely, we support quality reporting, reimbursement accuracy, and clinical transparency. Thanks for watching Health Code Blueprint. See you in the next video.